Okay, for the time saving, I'd like to start this session on live case 3, imaging and physiology and calcification. I'm Hong from Severance Hospital. My co-moderator is PK Koo from the Seoul National University Hospital. I'd like to invite several panelists, Yun-Kyeong and Dr. Hao from Hong Kong, and Jung-Ho, Kim, and Dr. Lim, Patrick Lim, and Dr. Murasato from Japan, and Dr. Sakurai from Japan, and Dr. Wong. There is 3 live cases from the Asan Medical Center. First case is Dr. Do-Yoon Kang. Dr. Kang, are you ready? Dr. Park.
Okay. Okay. Can you hear me?
Of course. Please.
Okay. Thank you. Thank you for inviting this afternoon the live case demo. And this session is specialized on the imaging and physiology guided PCI. Also, some how do you treat the calcified region. So I'm D.W. Park from Asan Medical Center. I'm introduced our team, our visiting fellow, the Dr. Faisal, and our senior fellow and the Yun-Kyeong Chai. And the Faisal, can you present patient background?
Definitely. So good afternoon, everyone. Our patient is a 71-year-old male with a history of diabetes, hypertension, dyslipidemia, and he was referred to our center for resting chest pain. His past medical history is only remarkable for having a previous stroke. Next. He's an ex-smoker as well. He's presenting to us with CCS functional class 4 angina. Next. His ECG is unremarkable other than first-degree AV block. Next. His chest X-ray is unremarkable. Next. His echocardiography was normal. His cardiac catheterization showed diffuse stenosis and calcification at the proximal to distal RCA and diffuse stenosis at the LCX ostium and proximal LCX, as well as moderate stenosis at the mid-LAD. Next. As we said, his RCA has diffuse disease involving the proximal and distal RCA, and his LCX is showing proximal calcified lesion that is well angulated. Next. His LAD, we did an FFR just now, and it was 0.77. Next. So our plan, our target lesions are the circumflex and the LAD, and we're planning to use IVAS guidance.
Okay, thank you. And so I'm going to summarize the first slide. So, and could you show us the first slide? A 71 years old male, and he had a multiple risk factor, the diabetics, and more than 10 years, and hypertension and hyperlipidemia. And the coronary angiography shows the triple vessel disease and proximity to RCA diffuse region. We will treat the stage the PCI. Today, we're gonna focus on the left coronary system. This is the aerial coral view, and very, angiographically interesting. And there is the diffuse and the calcified region, and the suck ostium and proximal suck is very tight. And distal suck also seems to be significantly narrowing. And next one. So, and this is the apicranial view, and as you can see, it's not much tight in the middle LAD part, and there is a severe calcified region, but the region length is extended from the distal lemma to the mid LAD. And next one. So, and this is the spiral view, and the suck ostium seems to be significantly compromised, and the distal lemma LAD ostium is on. Is there another view? Next one. Previous one. So, and yes, this is the LAD ostium. So, and the suck ostium looks tight before previous one. So, and this is the epicranial view. Also, we will show the first image. Yes. So, and at this moment, I would like to discuss how can we treat this patient. And I'm going to hear some comment from the panel and the moderator.
Okay, this is a really tough cases. Before starting a discussion, please tell us your treatment plan, and we will more discuss about the regarding your treatment plan.
Yes, so and we the last week we pre-reviewed this case with our team in the SJ and our another faculty, and there are some discussion point in the suck ostium and distal suck seems to be very tight, and and if FFR LAD is looks like intermediate region, FFR is okay. We just try to do exact stenting in the suck ostium in the distal one and proximal one is a 2 exact stenting would be okay. But the FFR is LAD was significantly compromised. We should treat more extensively is LAD long stent and suck long stent. And then after checking the IVUS thoroughly in the both branch, and if a significant atherosclerotic plaque and the narrowing is present, we do more systematic upfront two-stent stenting. That is our predefined planning.
There is no different opinion of the fixed the circ. It's a really tough, angulated and calcified. It's not easy, really tough cases. Would you show the epicranial view?
Okay, epicranial view.
And you worry about the severity of the mid-LAD. Looks like some severe, or it looks like intermediate. However, when you look at the size of the more distal LAD, compared to the distal LAD, mid-LAD portion is clearly smaller, definitely slow. So when we compare the diameter stenosis, the region severity, so we look at the more far distal or more proximal. And in the angiographic appearance, in the far distal LAD, diameter of the LAD is in this view almost be similar or greater than in the distal left main. So it means that the disease status may be extended from the mid LAD to the left main.
Yes, yes, it's a very nice comment.
Any other comment?
Yeah, so I agree that there's a diffuse disease, but the practical question is whether we fix those whole lesions with the very long stent or two stent, including the bifurcation two stenting, so that you already measured the FFR in LAD, which was 0.77, so that it will be interesting to see where was the pressure step up while you do a pullback, because that will be helpful in discriminating physiological lesion distribution and to determine the treatment strategy.
Yes, so and we are already checked up the FFR and from the mid LAD part, and so and the distal the distal part of the mid LAD's FFR was 0.77, and then the slightly gradually is going up. The first diagonal branch is portion is 0.86, and then the distal left main is 1.0. Is so I think gradually is going up the pressure, and on the basis of the FFR in the just mid LAD part, and looks like a free region segment part, this FFR was 0.77. So on the basis of FFR, we should treat the stent is long segment almost the mid LAD part.
So which means anatomically, physiologically, both long diffuse disease.
Absolutely, absolutely.
If you deploy the stent in the LAD, and what is the extent in the region distal to the proximal or distal left main, or?
So on the basis of the FFR, and we also checked the IVUS at this moment, is FFR can be used decision maker, is gatekeeper, treat or not treat. On the basis of the FFR, we should treat. So and that moment, and we already checked up IVUS. Could you show us IVUS from the mid LAD to the distal left main? Okay, shows that we're gonna show us the LAD IVUS here, and this is the just the mid distal LAD part, and the plaque over here, and the mid LAD part, and the lumen size 3.0, and the septal branch is coming, and the eccentric calcified region, and this area is narrow, and the additional the septal branch is also coming, and this is a severe calcified region, and the lumen seems like less than 3.0. The diffuse disease, this is a diagonal branch, yes, and huge plaque. Here is the vessel size is almost 3.5. And then the plaque was extended at the ostium as well as distal main. Could you speed up the LAD ostium slightly? Okay, here, pull back. So this is the plaque LAD, and the plaque was LAD ostium over here, and there is some calcium, it's some tight portion of the LAD. Also, this is distal left main, and the plaque was extended almost the shaft and the ostium of the left main disease. And on the basis of IBUS, there is no skip the free the segment zone, and we should do a full cover the mid LAD to the left main part. Also, we tried to check the IBUS in the SOC. Could you show Angel? So FFR is LAD was 0.77. We decided to treat, and the SOC is try to do past the IBUS. Next one.
So your plan is to extend from the mid LAD to the
Yes,
extend
next
to
one.
the left
하나씩
main,
넘기란 얘기야,
right?
여기는.
네.
Yeah, next one. 저기 바꿔서 해주실래요? The next one. So in the FFR, check it up. And so we try to the IBUS and does not pass the wear. And next one is the IBUS and does not pass the wear. And we should do a pre-dilation using the NC balloon. Next one. So, and the next one, this is a 3 point, is at the past the NC balloon, and there is a looks at the very severe tight suck ostium is a stenoric lesion, and this is a 3.25 NC balloon. Next one, and we do high pressure balloon dilation. Okay, next one, we did aggressive dilation using 3.25. Here and the distal sucker part is also narrowed. And next one, and the IBUS passage was not easy. We do aggressive NC balloon is several times. And the next one. So and the distal part is not past the IBUS, and we are also aggressive the dilation using 2.75 NC balloon. Next one. So this is the full the adaptation of the NC balloon to distal the sucker part. We also checked IBUS. Could you show IBUS and the sucker part? Okay, and this is the distal suck. Okay, the vessel size is 3.0. There's a plug is a start over here. Okay, we can see the calcium, and there is some dissection. Is 4 o'clock and 5 o'clock, and this is the distal. The suck is the narrowest part, and we did the aggressive pre-dilation using 2.75 NC balloon. Okay, and this is the most narrowest part of the distal suck. Is calcium was break down and expanded wear. And this is the mid distal, the suck. And then could you show us the more proximal part? Okay, here, start. So, and this is the most narrowest part is the calcium. We did the very aggressive NC balloon dilation using the 3.25, and the calcium is the most part is breakdown over here. So, and this is the ostium of the suck. And this is the distal left main, and the calcium was extended to the distal main. So we already used the imaging and the physiology. This is absolutely representative case. Imaging and physiology guided PCI is physiology is very helpful to decision making. It's a treat or not treat the LAD part. Also, imaging is very helpful to decide how can stenting strategy is chosen, and also the optimization for the complex procedure. So
The
and
reason
we
why I
thoroughly
asked
evaluated.
the LAD region is that if you the FFR at the proximal LAD is changed to 0.86, so the just planning to the stent and the mid LAD and the proximal LAD, that is maybe makes sense. However, in this patient is another lesion at the circ. So if you treat the maybe from the LAD to the left main, so the next step to access to the circ is maybe very difficult. So
Absolutely.
the sequence for the treatment vessel should be a circ first. The reason
Absolutely.
why circ is the region and the stent should be the more extended from the more left main. So circ first and then treat the LAD. And the second one is the educational point of view. If you introduce try to introduce the IBUS is the inability to pass over, you dilate it. But you see, even in the balloon dilation, there is some severe calcification. So therefore, after the stent deployment, I expect that there is some residual diameter narrowing even in the stent deployment. So
Absolutely.
at that time, think about the lower ablation first, rather than the balloon dilation.
Yes, like this, and this is we try to push the stent is did not pass well, like this. So we did the additional balloon, and if the stent did not pass well, we will use the guide giller. Okay, NC balloon을 다시 한번 줘볼까?
It is very
Then-
some educational point of view.
Absolutely.
In
I agree with
approach to the stent
Jung-Min.
is
From angle, in the CX proximal, there is a severe calcification. So at first IBUS unpass. So first road ablation is at first, and LED ostium is only calcification. So
20.
big road
Size
ablation
얼마지?
is performed.
20.
So
Okay.
LMT proximal LMT to proximal LD no stent, only DCB. So I avoid
Deplete.
two stent strategy, I think.
Okay. 20.
I totally agree,
22.
Dr.
24.
Murasato. I totally agree that when we encounter the IBUS passage to
22.
the calcified region,
24. Deplete.
think about the calcium ablation
24.
using the road ablator or something.
26.
If we can ablate the appropriately, we can
26.
perform the DCB treatment in the LSX. So, and the main issue is LSX ischemia, not so severe ischemia in the LAD. So we can avoid the LAD stenting or LMT stenting.
So in this case, the issue is LADOS because the LCX, we have treated the calcified lesion with the LOTA, so NC balloon is needed. But the problem is if we treated only the LCX, definitely something is happened on the LADOS. If we look at the IBUS of the image of the LADOS, definitely the disease is better. So I think that the DB is not enough to treat this lesion. So only the FFR, so we can treat this lesion by the spot stenting. But after checking IBUS, I changed my mind. Total metal jacket is needed in the full LAD and LCX.
I just got a question. No, so how many people in the audience will think about doing OCT or in the panel? But this is very calcified lesion, and we know compared with IVUS, calcium. OCT is able to look at the thickness of the calcium. So I just wonder,
But I think that in this case, LCX is nearly impossible to penetrate the OCT catheter. OCT catheter is
I know
more
that,
flexible.
but let's say we do a pre-dilatation and then try to do OCT.
So even though the angulation is not so good in this situation, but even though the stent is not so poorly they enter the LCX also maybe due to the angulation. So
자, 플릿, NAD 플릿. 한 번 더 들어갈게.
Yeah, I think in this case, Duk-Woo already performed a NC balloon angioplasty. We saw that the calcium is not circular and encircling, and there's a lot of calcium breakdown. So in this case, I think that the IVUS OCT can be used interchangeably. But I also agree that Williams thought that in a heavily calcified lesion, we generally prefer OCT rather than the IVUS.
So as you can see, this is the anchoring the technique, and it's sometimes helpful. Okay, test.
The message of this technique is that the stent was delivered in the third time,
들어가.
failure of the 2 times. So what is the message? Before the trial, when you look at the angiogram itself, before the stent deployment, it may be a possibility of very tough cases due to a very severe angulation and the calcification. We expect that.
14.
14.
Flip. So, and during complex PCI, there are many unexpected things happen. So, and you always have several things in your mind. And if first one step is failed, and second one, and second step is failed, and the third step. Third step was failed, and the fourth step. There is several choices. And during the complex PCI, you should have a very dynamic thinking. So go.
Educational point is that I like to say that,
14, 16.
okay, look at this kind of when you meet the next cases in the future, okay, this is a really tough cases. We have to expect that, not an unexpected finding.
So Dr. Duk-Woo, we've just discussed about the issues IVUS versus OCT, and you did a wonderful trial, Octavius trial. So after having equivalent results between IVUS and OCT, so what happened to you? More OCT, more IVUS?
So, and I think in this case, we published the recent paper is Octavius trial for the complex PCI subset, and that finding, we found the ISR region, OCT was definitely better than IVUS. So another interesting specific region is calcified region is OCT is provided more detailed information about the calcified region. So we can use the OCT and as well as IVUS. This case, and we already assigned the IVUS or OCT, and this patient was assigned IVUS. So I think OCT is also the good option for treat this patient.
Okay, Dr. Bach,
Yes.
continue your cases. We will be back.
Okay, thank you.
Okay. What is the next?
자, 여기 anchoring.
Dr. Ahn or Dr. Kang? Okay, Dr. Ahn.
Yes, good afternoon, Dr. Hong. Can you hear us?
Keep going on.
Okay.
Of course.
Okay, we are preparing another live case. So our senior fellow, Dr. Bob, will introduce patient history. Patient history is very interesting.
Hello, I'm Young-Sung Park from Asan Medical Center. I'm presenting the next case. A 70-year-old male was referred for efforting chest pain. He underwent PCI for proximal LAD in 2017 at other hospital. And he recently underwent DEB at left circumflex ostium and stenting at distal left circumflex at that hospital. Even after PCI at left circumflex, his symptoms didn't improve. Next. He had diabetes and hypertension, hyperlipidemia, and he was non-smoker. His clinical presentation was stable angina, functional class 2. Next. His ECG showed normal sinus rhythm, and there's no ST abnormality. And chest X-ray, there's no cardiomegaly. Next. And his echocardiography showed normal ejection fraction, 60%. Next. And this is the coronary angiography at outside hospital before PCI at left circumflex. In the LCA caudal view, there is a significant stenosis at ostium, left circumflex ostium, and moderate stenosis at distal circumflex. And the spider view, we can see the significant stenosis as the ostium of left circumflex. So he underwent PCI at the left circumflex. He had the DB with kissing balloon at ostium at the left circumflex and stenting with osteo 3.5 at distal left circumflex. And the spider view showed the residual stenosis after the stenting DB at the ostium of left circumflex. Next. Because his symptom didn't improve, we had the baseline coronary angiography. The RCA showed mild stenosis at proximal RCA. Next. And let's say caudal view, there seemed the patent stent in the distal left circumflex stent, and there's some haziness at the ostium left circumflex. And the LAO cranial view, we can see the instant restenosis at the proximal LAD stent. Next. And at the spider view and the LA caudal view, there's a haziness and there's some filling defect in the left circumflex ostium, so it seemed the coronary dissection. Next. And we checked the LAD FFR because of the proximal LAD ISR. And after hyperemia, the FFR decreased to the 0.81. Next. So our target lesion is distal main and left circumflex ostium.
Okay, what is the today's angiogram?
Could you show us the angio?
Yes.
Yeah. This is today's angiogram. So circ ostium, patient has a history that his angina didn't improve much even after the stenting at other hospital. After reviewing the other hospital angiogram, we found that some still residual stenosis even after balloon angioplasty at the circumflex ostium. So circumflex ostium is a frequent location of recoiling even after balloon angioplasty. So this is today's coronary angiogram. So how to evaluate the circ ostium? What is your idea?
Any comment from the panelist? Angiographically, it looks hazy. What it is, I really want to know, but I'm not sure what it is.
I'd like to check that with IBUS or OCT. Yeah.
What about the pressure wire? We don't need the pressure wire in the circ?
Oh, of course, pressure wire is good.
Any more comment?
I'd like to check the OCT is better to know how it's the stenotic region is occurred. So know the stenotic tissue characteristic is very important. Thrombus attachment is only dilation is available.
Dr. Murasato preferred the OCT. Please show us any kinds of the image or...
Yes, first of all, I insert the wire to the LAD and circumflex. So we perform the IBUS evaluation first.
Not OCT?
We will show. Our technicians are preparing the OCT evaluation according to their suggestion. So please wait for a while. Anyway, could you enjoy his IBUS finding?
Okay.
IBUS부터 먼저 보여줄래요? 네. This is the RCA pullback.
RCA? Circ.
Sorry, circ pullback. Yeah. Circumflex is a very big vessel for almost 4O superficial calcification at the here is a very ostium, proximal, and not ostium. But coming to the ostium, there is just some kind of here is a very ostial portion.
So it looks like calcium nodule there.
Yeah, it looks like the calcified nodule. Here is the left main.
Based on the IBUS finding, what is your planned treatment strategy?
Actually, I was sure that the very tight stenosis is due to calcified nodule. So I think that we need a stent implantation because the patient angina didn't improve much even after the balloon angioplasty. Could you show us LED progress?
What is the time interval from the DEB and in the
4
current
months.
time, the present time?
4 months ago.
This is some typical cases. We did the DEB in a larger vessel like that. So now we look at the angiographic finding. DEB is really working in this patient. Drug is really working. I think it's the vessel size too big. It was not penetrate the target for the advantage area.
So DB for the large vessel, preparing is very important. So gain the optimal lumen area. After the optimal lumen area and the DB is effective. So making some dissection and remove the intimal tissue, that is a very important point. So in this case, the root ablation is effective to remove the calcified nodule, and then the DCB is also effective, I think. So previous hospitals, they don't perform the root ablation and calcified modification. That is the reason why DB is not effective.
Yeah, sorry. OS is it is important to the wire bias. This IBUS image, distal side is wire bias is very good, but the proximal side is no good. So if OS use, it's dangerous, I think. So Moderator is good, better than OS.
What are you doing?
So I'd like to measure the FFR because the angiographic ambiguous. I was sure the very looks tight, but the IBUS catheter location may affect the IBUS finding. So I'd like to check the functional significance of osteum.
Okay.
So after equalization,
So what kind of pressure wire are you using, Professor Ahn?
this is Abbott.
Quite interesting. Let's bet what is the FFR value in this patient, and the match what is the final result. Dr. Koo, what about your expectation?
I think it's because the lesion was tight. It's around 0.78 or 82 something.
7, 8.
Okay, it's around 7.8 or so. It range 7.8 to 0.82.
You are an expert. You are more closely matched.
No, so it's physiology, so no one can do that.
So Dr.
Okay.
Koo, we will also do the RFR for this case as well. So you look at the FFR and RFR together, or just focus on FFR?
I'd rather prefer, because this is very relatively short lesion, so that the RFR maybe underestimate the lesion severity, but here RFR is almost 1.
Okay, keep going.
Yeah.
Please show us the final
This is a
result.
very unexpected finding. So could you infuse the adenosine, 140 microgram per kg per minute, usual infusion rate.
Who said that is around 0.78, around
Yeah, 7.8 to 82.
That's an interesting case because the resting is normal. So
Yeah,
let's see on the high
perfectly
image.
normal.
Yes. Yesterday, Dr. Akasaka is saying that we should do both. And then decide on which one is the lowest. So let's see on this case.
Is there anybody bet that the more than 0.85, above the 0.85 or below the 0.75? Is there anybody?
Yeah, because the resting is absolutely normal. No, so I would expect no student be lower than 0.85, honestly. Because the resting is 1.
So hyperemia is starting, and the PDPA is 0.91, 90.
It
So
should be
I think
anyhow approach the 0.82 because Dr. Koo said that. So
Could you give us
more
the
hyperemia.
200? Huh?
But may I ask if
So
anyone
give us the
depend
200 microgram.
Okay, good. It makes around 0.82 at least.
But the reason why I still measure FFR is I cannot predict the FFR accurately. So that's the simple, and that's the
I think
physiology.
FFR is 0.91. This is slow pullback. No pressure jump up.
No whiskey.
Anyway, here we just stand proximal, so 0.93. Okay, at the ostium, in the guiding catheter, PDPA is 1. So
For my point
definite-
of view, this case is really educational and the interesting case to show the real value of the pressure wire.
So could you give us the OCT?
What about
Actually, I'd like to show you another interesting finding. Could you show us the LED pullback IVUS? He had a LED stent implantation. So LED stent IVUS finding is interesting. 여기도 좀 바꿔줄래요? So LED vessel size is actually very big, almost 4O. What size was implanted in the LED? 3O?
We did not.
So we don't have, actually we don't have any information about stent size. But to look at compare with the vessel size, stent is actually very expanded, but compared to the vessel size, the stent size looks small, only 3O. Some neointim hyperplasia. This is actually the ostium of LAD. We already performed the LAD FFR before. LAD FFR is 0.81. So the FFR value is above the ischemic threshold, but the stent doesn't look like the optimally implanted. This is another point I want to show. Even though at this moment I don't like to touch the LAD anymore.
What about the circ? Do you fix
So-
the circ or not?
So could you show us the I will show you the circus stent again. Circ, IVUS.
So you have a LADFFR 0.81 and circumflex 0.9. So the practical question for the patient may be why the patient still have chest pain.
Yeah, that is very important because the science is should provides the objective number. So at least based on the FFR evaluation, pressure evaluation, the perfusion pressure should be good. So we cannot trust that we can 100% the patient the symptoms. So sometimes the patient is so sensitive for some chest discomfort. So actually. That's why we need the FFR evaluation when patients complain the unexpected the feeling or discomfort. Another issue is in this case, if we implant the stent to the circ, then patient symptom could be improved. Okay, this is a circumflex. Previous circumflex stent. No. Okay. Circumflex vessel is 1, 2, 3, 4, almost 4. But stent is around 3.
3.5. The stent was 003.5
Outside of
was 18 millimeter.
Okay. Circus stent it looks bigger than LAD stent. So actually, previous pressure wire pullback, there is no pressure gradient through the circus stent. So circle is very well implanted. So my technicians already prepared the OCT.
So, Dr. Murasato, you've seen the IBUS images, and you'll see the OCT and heavy calcification, small lumen, but FFR 0.9. Are you going to treat or not?
There is no serious myocardial ischemia in the SX, so I leave it. However, sometimes there is a discrepancy in the minimal lumen area and the FFR drop. In the OCT, minimal lumen area less than 2.0 millimeter square. That is acceptable for the treating. However, FFR drop is not so serious. That's 0.9. In this case, I leave it.
So with this kind of very tight stenosis IBUS or the OCT, you're not going to measure FFR in daily practice.
Yes, in Japan, the moderate stenosis is applicable for the FFR measurement. So more than 90% stenosis is not applicable for the FFR for the reimbursement. So we found that 90% in the LSEX RCA, we directly perform the imaging and confirm the tight stenosis and perform the PCI. That is my style.
해봅시다. Ready? 안 되면 가이드 찔러쓸게요. 네. 가이드 찔러주세요.
The other reason is not our interest. We only show the awesome of the circle.
Yeah. I do my best to make a good imaging. OCT 보여주시겠어요? 네. 네.
Excuse me, blood removal is not so good. So more retrieve the OCT catheter more proximal. And especially left main evaluation is not poor. However, the minimum lumen area is very small.
This is a guide chiller to make a clear imaging. I'm using guide chiller.
Telescope is better. Telescope has a helical core, and between the helical core, we can see the vascular tissue. So especially in the left main, using a telescope is better when we perform the OCT.
갑시다. 예. I think that this is you can see that the location of wire is very this side. So lumen, there is some lumen to the opposite side. So imaging may. So that's why imaging show that the smaller than FFR value.
I think
Actual lumen.
blood clearing is not perfect. It makes the artificially create some
maybe calcified nodule extended from the 10 or 12 o'clock. So large calcified nodule.
Yeah.
And 5 o'clock and 7 o'clock, there is a lumen and connected to the proximal side. So, so flattened lumen, here, it's connected.
Yeah, right. I agree. 조금 더 내려가 주세요. 조금 더 내려서 조금 더 위에 올라가서 더 입구로 쪽으로 더 입구 쪽 더 프록시말 더 프록시말 두 개로 나눠준 데를 찾아봐. 더 입구 쪽 여기 조금 더 프록시말 네. I think there is a two lumen due to the calcified nodule. So the wire is go through the smaller lumen, but the opposite side there could be a larger lumen. So that's why the FFR flow is good, but the IVUS looks a smaller minimal lumen area.
Okay.
Anyway, what is your opinion? Do we need to put the stent for this patient?
Anybody who wanted the stent deployment in the panelist? Dr. Koo, Dr. Murasato?
No, so I don't want to put stent there.
I think there is a risk of the growing the calcified nodule in this region. After the root ablation, is effective to ablate the calcified nodule. So the stenting is not agree for me. So ablation with the root ablation and DCB again.
Any other opinion?
So in this case, show that the typical example of it's very difficult to good image of the LCX OS region because the guiding catheter angulation is very difficult to get the image qualification. Also, another thing is the FFR value is above the gray zone level. So that means if the FFR value is around the 0.5, I think about the stenting is possible. But this FFR value nearly that 0.9. I don't think that it's not a good idea to put the stent in this area. Just leave it alone and medical therapy, and after checking the angiogram after the 6 months or that 1 year later.
First one is the symptom was improved after the DEB, and second one is that the objective evidence is pressure-wise more than around the 0.9. Finally, there is this is some general meaning is that is there any debate? Is not a critical. Is the debate. My personal bias is just leave it alone in observation. So, what do you think about Dr. Han? Do you
Yes,
want to?
I fully agree with your opinions. So, initially we planned to do some procedure, but after FFR measurement, we totally changed our mind. Just leave it alone under the optimal medical treatment. So, if a patient symptom more aggravated, then we will angio again and check FFR again.
Okay, great job is to show us the clinical implication of the pressure wire in the real practice. Is a really good cases. Thank you, your procedure. We will move to the next cases. Great job.
Thank you. Thank you.
Dr. Kang. Dr. Kang.
Yes, I can hear you.
Okay, please show us your cases.
Yes, thank you. I'm Dr. Do-Yoon, and I will introduce my team, the Sang Young-ju, our senior interventional fellow, and our technicians, Seung-Yong, and he's helping me. And Dr. Jo, can you please present the case?
Thank you. Okay. Thank you for the introduction. This is live case briefing. A 54-year-old man was referred for dyspnea on exertion. He has been treated with hypertension and dyslipidemia. He is nothing special on past medical history. Next. His clinical presentation was stable angina, functional class 2. Next. His electrocardiogram shows normal sinus rhythm. Next. Chest X-ray is no abnormal finding. Next. Echocardiography shows a kinesia of LV apical septum and apical imperial wall. Next. It is a baseline coronary angiography. His RCA was very tortuous, but definitive stenosis was not seen. From RCA to LAD collateral flow was seen. Next. He has very long left main shaft and trifurcation. This, from distal left main to proximal LAD was a significant stenosis. His left circumflex artery has also diffuse long stenotic lesion, but maybe blood vessel size seemed to be small. Next. Mid LAD lesion was chronic total occlusion, but distal weak competition flow was seen. Next. Yes, our target region is distal left main and proximal LAD. And if we can try mid LAD CTO. Thank you.
Thank you for your presentation. A relatively young guy with important angina that showed severe prox LAD and left main, distal left main disease, and also LAD CTO. Actually, the LAD CTO has a good collateral from the RCA, the rental grade 3. And actually, we know that in our decision CTO, the trial that at those the mid-LAD CTO with a good collateral branch, the just medical therapy is equal to the PCI. However, the patient has the also left main disease, so we plan to treat both of the mid-LAD CTO and the left main. And can I progress some more? Because as you can see in the angiography, there is some LAD antegrade flow, weak, but you can see, and next. And in the spider view, you can see very severe calcified disease at the proximal LAD ostium. And unfortunately, the left main is widely opened and the angle to the big circumflex is opened. Next. And we check the tip angio, and next. And luckily, there was some false remain. Next. And next. And with the Gaia second wire, we could cross. However, after the crossing, there was no antegrade flow, so we checked the bilateral angio with the radial approach. And we could see that we are in the right way. The CTO itself was not very complex, so did not take a long time. Next. And we change it, but I could feel the very severe the resistance during the mid LAD corsair introduction. And next. And applied balloon, and you could see it's not NC balloon, but compliant balloon, but you can see the balloon is not fully inflated in nominal pressure. And we check the IVUS. Can you please show the IVUS from the mid LAD to left main? After then, maybe we can discuss about the treatment plan. Next, IVUS. Okay. This is the 엔조도 같이 보여주세요. This is the IVUS from the mid-LAD. And distal to the CTO region, there's some diffuse lesion. However, the distal edge was clean. That would be landing zone. And you can see some instrument that I made with the wire. And also, this is after ballooning. There's some balloon-related dissection. It's not very heavily calcified, but here you can see some calcification. And this is the ostium to the mid-LAD. And diagonal branch. And there is very large positive remodeling proximal to the CTO segment at the prox LAD. Here, the vessel size is more than 4.5, very huge, and mild plaque. And soon, at the LAD ostium, there is heavy calcification, maybe the calcified plaque at the ostium protruding to the left main. Here is the left main, the large lumen. This is where we are. 네, NGO 한번 다시. 네.
Any comment about the treatment plan?
Actually, we planned to open all the segment and put the stent. However, what I am considering is to debulk the proximal LAD, calcification, maybe the calcium nodule, and the medial LAD, calcified disease, with some rotational atherectomy.
Any comment? Okay, go ahead.
I was finding already ostium, there is a severe
ostium
calcification, so I choose a
ostium.
low operator. A big
What size of a bar?
what size guiding caster? 7 French?
Guiding
8
caster
French?
is 7. It's 7.
I would like to 2.0.
2.0.
Yeah,
Wow,
bigger
very
bar.
large.
Big size of bar. Dr. Murasato?
And at first, the guide wire crossing the CTO is interplaque, very safely dilated. And at that site, the deep calcification, so the CTO site is ballooning and stenting is effective. However, the Japanese doctors say the SX, the LAD ostium has a serious calcified nodule, so 2.0 meter root ablation is effective to ablate. And guide wire bias is very favorable.
So
other
Rota is a
opinion?
good option, but in this case, they didn't the balloon angioplasty not fully. So I tried the NC balloon at the LAD OS region, maybe such as the 3.0 or 3.5. After that, make
Balloon
angiography.
3.0.
Yeah.
Any other opinion?
So if there's a choice of IVL, would anybody consider using IVL? But
We don't
I know
have.
in Korea don't have, but let's say, we can use IVL for this case. I just wonder, Dr. Wong,
I
in
really
Hong Kong,
want
we
that
got
IVL,
IVL.
yeah.
Yes,
but-
yeah, we do have IVL, and actually it's quite a suitable lesion.
Yeah.
It's quite just a simple lesion, and we are dealing with very deep calcium. So the older patients might not be able to touch that deep calcium that we are trying to treat, which IVL can.
For me, after the intravascular examination, I will fix it just straightforward. The reason why, the basal proximal LAD almost be more than a 5. So my concern is not the presence of the calcium, the size of the stent, which size of the available for the proximal LAD around the 5. So if I deploy the 5 stent deployment at that, maybe there is the shape is some eccentric. However, the final stent area is maybe bigger. So in this situation, maybe we need some debulking it. I have some question. So simply, so predilation 3.0 for me is the 4.0 or more than 4.5 non-compliance balloon, and then deploy it, and then what happened is just simply go ahead. And especially in the mid to distal LAD, I'm finding is that the vessel size almost be 3.5. It's a very, very big size of the vessel. Okay, what
Thank
is
you for your opinion, and I also agree with that the ballooning is very important, and also the applying the very high pressure will work, and for the proximity we will need a very large stent, minimal 4.0, and we will need the further bigger high pressure balloon. But in this
Don't you
case,
have
as
the
Megatron? Yeah, that will be a very good option. Yeah. So, but in this case, as we planned, I use a rotablation run for debulking of some segment, and then we will do the NC balloon, and we'll put the stent.
Okay, go ahead.
This is the rotablator on not a new version, but the old version. This is 1.5.
Is it 1.5?
Yeah.
The recommendation is 2.0.
2.0 it was. But
You will upgrade
First
with.
operation, wrote
Okay.
1.5 is okay. And second step, and 2.0.
actually, I prefer to begin with a smaller one. Yeah, but I'm not so brave yet. Yeah.
Yeah, one of the educational or interesting point. Okay, let's see. 1.5, and then please show us that the IBS image. What changes that the shown 1.5 in this region?
Yeah, it will be very educational. Are you ready? Yeah, ready. Yeah. This is 1.5 run. There's a weak resistance, not so severe. And
Technical point of view, very smooth passage. It suggests that
Is there any burst speed to drop?
burst speed is about 200,000.
There is no change.
Yeah, no change. Yeah. I think the 1.5 is a little bit small for the working of the here. Here is the point. I'm feeling a bit resistance. And actually, I want to go further, but there's some resistance in the mid-area region. It's a CTO segment.
Excuse me, where is your target with load operator?
Actually, my original target is the proximal LAD for
Proximal-
debulking of the calcium nodule.
I think only LED ostium.
Yeah.
So, in the mid LEDs, not enough.
Okay. But I still have some resistance in the mid LED, and there was some calcification. So I just want to open the opening of the CTO because I have 1.5 now.
Maybe you feel that this some difficulty to advance some devices because of the guide wire pathway is inside the plug. So another lumen of the microchannel. So that is the reason of why you cannot pass easily. So direct this lumen as a bigger balloon, 2.5 or something, you can pass through the easily. So the calcification is a deep size. So I don't think the load ablation is effective to this problem in the CTO side.
Yeah, then I will follow your opinion. And because with the 1.5 ball, as you feel, the debulking is not enough, I think. But after removing the rotor, I will check the IVUS, whether there is some change or not.
okay.
Start. Okay. That's the wire position.
Dr. Kang,
Yep.
after you will show us the IBS image after the load ablation, we will move
Yes.
to the DW box cases, and we will be back again.
Okay. Yep.
Okay, please show us the IBS image.
Yes, we'll check the IVUS. Would you move to? Okay, I will check the IVUS first. Here is the prox LED. You can
Show us
see.
the proximal LED. That is our interest. Okay.
Okay, we could not pass through. Because the left main was very long. It was not CTO segment, but it was the ostium segment. I had some misconception. Here,
This is a 5-0.
yeah.
Yeah.
Here is the ostium.
Okay. This is a really huge vessel.
Yeah.
Okay. Keep going on with your procedure. We will be
Yes.
back. Okay. DW box.
Okay.
우리 저기
Okay. Could you
Okay,
show us
so-
your procedure?
Okay, so we are finished the overall procedure. So on the basis of the IBUS and physiologic finding, we decide totally treat the whole segment of the sock and the whole segment LAD. And for that main part, we will plan to the crush technique. So and the first distal sock, we put the Resolute and the 26 and 3.0, and the proximal part is a 3.5 Resolute, and we try to match the ostium. Next one is the NC balloon in the left main part. We place the 3.5 NC balloon, and this moment we try to exactly match the ostium of the sock, ostium of the stand. This is the minimal crest technique. And then next one, we inflated 3.5 NC 3.5 Resolute stand, and then next one. So, and we did a very aggressive high pressure balloon dilation in the whole segment, sock and the distal part. We inflated 3.5 NC balloon, 3.0 NC balloon. Proximal part is 3.5. And next one, and this is 3.0. And next one is a 3.0 NC balloon. Next one. And the next one, 3.0, and this part is 3.5. We did the 3.5 NC balloon, next one. And then the 3.5 at the inflated up to 24 ATM, next one. And this is the part that high aggressive NC balloon, 3.5, more than 20 ATM. And the next one. And the sock ostium that is a very important step. And if you're gonna do full expansion is the side branch ostium, like a sock ostium, you can avoid abluminal wire narrowing. And as shown yesterday, Dr. Murasato, and if you do not fully expand it in the side branch ostium, you have a possibility in the chance to the abluminal narrowing. If you want to do abluminal the wire, the passaging is overall the procedure to be complex. So, and we did 3.5 inflated up to 30 ATM. And the next one, and this is aggressive the inflation again. Next one, and then we pull back the overall the system in the sock, and we did 3.5 high pressure balloon dilation. And next one. And the high pressure again, next one. And so, and we evaluated the whole segment, and we decided 3.0, 26 Resolute, and then proximal part 3.5, 20, additional 6, the Resolute, next one. And inflated one stand and the middle part, and next one. And then next one. Next, we try to match the overlapping is stand zooming, and next one. And we inflate, next one. So we did a very high aggressive NC balloon dilation using 3.0, and next one. This is 3.0, next. And the next. This is 3.5, next. And the 3.5, next. And the 3.5, next. And the next. And then here, next. And then try to match, and the next one. And then here, and the next, and we inflated up to 30 ATM using 3.5, next one. So, and we will check the recrossed the wire, and the next one. So could you show the final, the kissing step? So we did the final, the kissing balloon using the 3.5 and 3.5, and the sock ostium, okay, here, and the 3.5, and the added ostium in the 3.5, and next one. And next one. And the 2 times next. This is the nearly final, the angio and the spider view is looks beautiful, and next one. So this is the area coral view. We can see is a complex region to be simplified. It's a very straightforward region. And next one. Okay, this is we removed. This is the final shot. We already checked the IBUS. Could you show us the proximal circle part, also proximal LED part to show how the is okay? Show play. This is 여기 어디죠? The sock ostium. initially there is a very severe calcium, and we aggressively expanded the high pressure balloon dilation. This is coming here is the LED is coming the 6 o'clock, and this is the distal and main. Also, could you show us prox LED? And the distal part is expanded well. Prox LED만 보여주면 돼요. Okay.
Could you show us the bifurcation transition? That is the
transition point만 보여주면 돼. Okay. Play. So this is the LED ostium. So in the side branches, the circle is coming. Carina just 1 or 2 the strut. And this part is the distal limb main, and the fully expanded stand was extended to the limb main ostium, and this is the final view. So I think in this case we learned a lot of things and geographically we have a lot of ambiguity. How can you treat? How can you decide the stenting strategy? Just the stenting and the circle territory, or just leave it alone LED? And so we evaluated the available the tools and the physiology tool and the full imaging tool. That is some sort of a state-of-art PCI. This is a diabetic patient. You know, contemporary the guidelines still recommended the bypass surgery is class 1. However, that was based on 20 years ago freedom trial, validity trial. Nowadays, we have a lot of options. Imaging-guided PCI, physiology-guided PCI, adjunctive drug was developed. Even diabetic patient, we have a GLP-1 agonist, SGLT2 inhibitor, a lot of medication, a lot of tools. So I think we will do for the clinical trial, and in the near future, we will have a more compelling evidence, state-of-art PCI supported by imaging and physiology. The PCI would comparable to the conventional bypass surgery. This is a typical example, multivessel, diabetic disease, and the complex region.
Considering the severity and very tortuosity and the severe calcium, your final result is excellent. And what is the final focus is left main bifurcation. Only one segment was there is a stent strut. If there is no existence of the stent strut, is very, very perfect. Anyhow, the current finding is the excellent finding. And in the angiographic images, look at the ostium of the circ. There is some dense intensity compared to the other stent intensity. It means that some stent strut was a downside of it. It means you did the correct crushing. And at the carina, there is a slight the stent strut density in the carina portion. That must be the correspond to the IVE's finding. Overall, your whole procedure is a very, very excellent and educational cases.
So, Dr. Bach, I would say congratulations, but in comparison with the previous Nanjing live demonstration, the same left main, but it is interesting that your procedures seem to be much simpler because the Professor Xiaolong Chen did lots of, DK crush and lots of pop procedures, but you did a kind of minimal crush and then finished kissing balloon inflation without pop. So do you think that kind of differences in approaches make difference in outcome, or because you have a perfect result by the IVUS, it will be fine?
Yeah, so I think that is a very important point. And in the DK crush, and is a wonderful double stenting technique. DK crush is specifically emphasize a part and repart. So I think we do sometimes a part. If you're gonna do, at this case, we will do additional part and make a more, this is as shown in the IBUS, we can make a more concentric portion. But we don't have enough data about such, concentric configuration and the eccentric configuration make some difference in outcome. But however, on the basis of a larger cumulative our experience, we don't do is part and repart. Its overall outcome was excellent. So, and it's depending on the personal experience and the personal expertise. If you have some confidence about your procedure, we can omit this part of repart. And the lumen was expanded well, and the lumen size, minimal standard size is enough. That is a guarantee, is a long-term is favorable outcome.
I think the technique is not important. Minimal crush, decay crush. What is and then what is the final result? Final result from the image. What final stand lumen area, particularly in the ostium of circle. It determined the finally the outcome. Okay, great job. We
Thank
will
you.
do the Dr. Kang's cases.
Thank you very much. Okay, 잘했어요.
Dr. Kang.
Yeah, thank you. Thank you for visiting us again. Yeah. Actually, I did the 1.5 lota, and after that, we checked the IVUS, but there was no big change. I think that the one would be the lota size is small. Second would be that there was the bias that because the lumen was placed at the lesser curvature, but the rotablator did not effectively ablate the calcium. So I 100% agree that the intravascular lithotripsy will work very well in this case. And I followed Dr. Hong's opinion and applied 4.25 NC balloon at the LAD ostium. And can you please show the IVUS at the proxy after ballooning?
What size of the balloon? Approximately
4.25 NC.
4.25.
Yeah, up to 20 ATM.
Quite big size of a balloon.
Yeah, because we know that the vessel size is more than 4.5.
So everybody they have the worry about that. It's a too big size of it. There is a risk of the population. What happened?
I think that it will be okay. As you said, the vessel size is quite big. Because we know the vessel with the IVUS. With the angio, it just looks like maybe we would put the 3.5 and apply 4.0 at the left main. But with the IVUS, we know that the vessel size is more than 4 and medial AD, and at left main is more than 5. Yeah.
What size of the stand at this time?
I
Second
placed
stand?
first stand is a 3.0 by 48 synergy because the distal vessel became larger and larger with the nitro injection, and now it's 3.0. And this is the Megatron 4.0 to put the medial AD to
4.0, not 5.0.
Oh yeah, because the medial AD was not so large. Yeah. If I put the stand at the very proximal AD to left main, I would put the 4.5 or 5.0. But the medial AD, the stand overlap zone was not so big. So I will put the 4.0 and will apply further bigger NC balloon. Test? Yes. Okay. Let's overlap. Okay. 들어갑시다. 노미나. 11.
Up to 20. 20 is okay.
Pressure. I will a little bit protrude the balloon and apply bigger pressures. Okay, 20. 4.53. Pressure. Okay. Because the CTO segment was a little bit long, so the standard overlap area was just proximal to the diagonal branch. So their vessel size was not so big. 저 NC 발론 주세요. 아까 나온 거. 작은 거부터. 2.75. I will apply 2.75 and we need 3.0. We will use the 3.0 NC 3.0. 3.0. Yeah. 3.0 for the medial AD and 4.25 for the proximal AD. And even if there is some malposition at the left main, I will use for the big short balloon for the left main. Because these balloons we already have. used. This is 3.0. And CTO segment, so PCI was about 3.2 at the mid nominal. 14, 16, depletion, 18, 20, 22, 3.115. Depletion, 26, 3.2. Depletion, 26, 28. Depletion, 4.6 있는 거 주세요. This is a 4.25 NC that I have used to open the LED ostium. What is the burst pressure of this balloon?
Burst 달라요.
Okay. Six, 8, 8, 10, 10, 12, depletion. Approximately, I will be to the bigger pressure. 20, 22. It's about 4.5 or more. We need a little bit long time inflation to treat the calcified lesion. Depletion. And the old report from the Antonio Colombo has a 30 seconds is needed. 24. 26. 4.6. Depletion. 26. 28.
So Dr. Murasato, in your team's
Depletion.
previous trial, showed that the kind of a 10-15 seconds and repeated balloon inflation is more effective than one-time long inflation.
Yes.
So can you teach us about that for this calcified lesion?
Yeah, especially this kind of the calcified region, the 3 times inflation is effective to compare to the 60-second one-time long inflation. So 20-second 1 to 3 is effective to get more stent area. So the short inflation 5 seconds is not enough. 20 second, 20 second, 20 second is effective.
Then how about in left main? Do you also apply the long inflation, 20 seconds?
Yeah, 10 seconds 3 times.
10 seconds, 3 times. Great. Because now, because I am the very young interventionist that I did not have the experience of the POBA. And nowadays we are using the DB. So now I became to know, my senior already knows, but I now know that the patient is very well with the long time inflation. And here we are the mid-LED. This was the CTO segment. And I apply 3.0 stent and balloon. This is the opening of the CTO with some calcification to septal branch. And well opened. And diagonal branch. And here's the transition to the Megatron. You can see more, much more stent strut. And I apply 4.25 here. As you can see, the vessel size is about 5.0. Yeah. Very large vessel. Fully opposed, I think the lumen area would be more than 15. And here, the ostium of the RI, the circumflex. And we cannot find the nodules or some debris or more. And here's the left main. how do you think about this result, Professor Hong? We
Excellent.
need more dilation or
No.
enough with
Excellent.
this?
Actually, angiographic appearance itself does not need the IBC examination.
Yes.
It's a too big size of it. The only purpose of the IBC in this patient is that to evaluate the presence of the stent malposition in the left main. That's it.
Yes.
It's
Left
too
main
huge.
보여주세요.
It's an excellent lesion.
Left main 다시 한번 보여주세요. Can you please show the ostium of the prox LAD? And I will check the spider view. Angio? The ostium of the circumflex is a little bit ambiguous always after the crossover because there is some calcification and strut and the angiographic view is not so good. But in IVUS and this image from the 11 o'clock, the widely opened branch is coming in. The flow is chemistry, so I do not concern about the circumflex so much.
Excellent job. Congratulations. Any other comment from the panel? Okay, excellent job. And any other, Dr. Kang, any comment? Do-Yoon Kang?
Yeah. Actually, I'm very happy with this result because the CTO was opened and very lucky, and the mid LAD was well dilated. And I think that in this case, debulking with the low tabulation would not be very effective, but maybe the lithotripsy or something like that would be much better. And thank you for your opinion and comments that we could do that.
Okay, great job.
Thank you. Yeah.
We will
Thank
move
you.
the next presentation. Next presentation is my co-moderator, Physiology-Guided Decision Making, BK Koo.
Thank you, Professor Hong. So good afternoon, ladies and gentlemen. So some may think that this title may be a little bit provocative because some think that the invasive physiology study is only for simple lesions, so there will be no role of physiology for complex PCI. And for some who are not that accustomed to physiology, physiology itself is complex or complicated procedure, so any physiology-guided PCI to them will be a complex PCI. So I think it's more likely a psychological thing rather than a data evidence of guideline thing. So today I'd like to share some cases to show how the physiology can be integrated in guidance for complex PCI during daily practice, and starting with the left main and bifurcation lesions. So this case, 63-year-old gentleman presented with unstable angina. Right coronary artery has a very tight stenosis, which seems to be culprit for the instability of his symptom. But there's another lesion, distal left main and LAD ostium. And MLA by IVUS was 3.0 square millimeter. So the practical question to have while accounting this case may be that right coronary artery may be not a tough lesion, but how we can treat the distal left main lesion and which technique will be the best. But before you move on, when you measure FFR, you'll get to know that it's 0.85, like the previous case for the circumflex ostial lesion. Then, with one FFR measurement, this lesion from the complicated case to a very simple lesion that can be fixed with the one drug-eluting stent, you may still worry about that left main and LAD osteostenosis, but you may be reassured that when you see these follow-up MPI images where there is no reversible defect in LAD or circumflex territory. So here's another case. This angio was taken 14 years after implanting cipher stent left main to LAD, and you see there's a quite tight stenosis of big first diagonal branches and also circumflex. So when you encounter this lesion, if you want to fix it, you will have to prepare for a complex PCI for 14-year-old jail circumflex and diagonal branches. But when you measure FFR, IFR, first diagonal branch IFR 0.96, FFR 0.87, and circumflex IFR 1.0, FFR 0.93, so that no need of complex PCI, but simple medical treatment will be enough for this case. Then let's move on to the multi-lesion, multi-vessel, and diffuse lesion. So relatively young female patient, stable angina. So the patient seemed to have a multiple disease, distal left main, proximal AD, 3 lesions in circumflex, and 3 lesions in right coronary artery. So we can code it, this patient as having by angiogram, distal left main disease plus triple vessel disease, 8 lesion. So the question is surgery, or how many stents we can implant in this patient. But if you measure FFR, LAD 0.83 and circumflex 0.88, so LCA, no functionally significant disease anymore, and RCA 0.65. So this may be the culprit for the patient's symptom. So now the patient transferred into the single vessel disease, but right coronary artery still have 3 lesions, and when you do a pullback, you can get to recognize that the number 7 lesion may be the primary target for this treatment. So by angio, triple vessel disease, distal left main, 8 lesions, and now the patient has been transferred into the 1 vessel disease, and that can be fixed with the 1 drug-eluting stent by FFR guidance. So this is how physiology can help your complex PCI into a simple one. And here is another case with the very diffuse disease, typical DM-like patients from left main to proximal LAD, mid LAD, and also diagonal has a very long diffuse disease. So if you want to fix all these lesions, we have to be ready for full metal jacket, including complex bifurcation PCI. And IFR for this case at this LAD was 0.87. But when you do IFR and angio co-registration system like you are doing with the OCT system, you can see that the dots are gathered as some segments, so that the yellow dot represents the changes of IFR 0.1, and you see that the 0.01, and you see that the lots of dots are accumulated in the mid LAD segment, and you can fix this lesion without even touching diagonal branch ostium, and estimated IFR after this PCI will be 0.98, so that the single stent will be enough in terms of physiologic lesion distribution. Then we are talking a lot about DCB nowadays, and we know that from this very excellent consensus document, there is a criteria for DCB according to the angiographic result, so that I borrowed this case from Professor Shin, who is the master of the DCB. So mid-LAD, very tight lesion, balloon angioplasty. So there's no flow-limiting dissection, but residual stenosis is around 30 to 40%. So I would say it's around intermediate degree of the acceptable angiographic results. But when you see this OCT images, there's lots of dissections, minimal lumen area, almost less than 1, so that you will not be satisfied with this result, so that even if by the angio it looks fine, but this lesion is very kind of a horrible lesion, so it's hard to do a DCB for this case. But Professor Shin measured FFR 0.87 despite those dissections, so she finished the procedure with DCB, and after 9 months you see that the perfect results at the follow-up angiogram of that mid-LAD lesion, along with the complete resolution of those dissections. So this is how the physiology can be helpful in assessing the angiographic successful results after balloon angioplasty. And finally, I'd like to show a 1 coronary anomaly case. This is anomalous RCA from left sinus of Valsalva. You know that this is a quite complex physiology. So here, compression between the pulmonary artery and aorta, this is the matter. By the IVUS, also that this ostium is compressed by the aorta and pulmonary trunk. So the issue is how we assess, how we fix this lesion. Generally, surgery was the treatment option for these cases, but now we can sometimes do a PCI for this case. But before we do that, we have to assess this patient. So it's not that difficult to measure FFR 0.91, but if you understand the physiology of this, pathophysiology of this lesion, this is a dynamic compression. So that degree of stenosis will get worse when patients do exercise and when patients is under the emotional stress or physical stress. So we have to mimic that dynamic compression, so giving dobutamine and atropine, which will increase the heart rate to 180, and blood pressure will go up only 200 millimeter mercury, so it's like a dobutamine stress echo. So for this very complex anatomical disease, we're doing a complicated physiologic studies, what we call it double time stress FFR, but still FFR is 0.87, so that I can confidently do a medical treatment for these patients, not sending the patient to the surgery. So I started my talk with this kind of skepticism about the concept of the physiology for complex PCI, but I hope that now you think that the physiology is an essential element for understanding patient disease status and clinical decision making, and it can help to select the appropriate treatment strategy and sometimes make the complex PCI simple in daily practice. Thank you very much for your kind attention.
So the next speaker is our chair, Professor Myeong-Ki, and the title of his talk going to be Imaging-Guided Optimization in Complex PCI.
Thank you. I'd like to talk about the imaging-guided optimization in the complex PCI. My disclosure. As we know, there is a change of the treatment strategy during the PCI when we use the intravascular imaging. Is that the percentage is 74% higher percentage. When we know that in the long region segment and compared to the angio-guided PCI, the clinical outcome is that the IBS guidance is quite more favorable, and this result was clearly shown in the IBS subgroup compared to the patient not meeting the IBS optimum criteria. The incidence of the clinical event is significantly lower in patient meeting the IBS criteria. This kind of finding was confirmed in the ultimate trial. In this study, the study population is the all-comer patient. In both two study, reduction of MACE driven by the reduction of the TRI. It means that the reduction from the soft endpoint, not the hard endpoint. This is a very the famous slide, the stand optimization criteria. There are several factors to determine the stand optimization. Minimum stand area and the stand expansion maloposition and the tissue prolapse and the dissection. Among 5 variables, the minimum stand cross-sectional area is most important to determine the stand optimization. We combined the all patient in the IBS XPR and the ultimate trial and demonstrate the use of the intravascular imaging. Demonstrate the more reduction of the hard endpoint, including the cardiac death or composite of cardiac death or MI or stent thrombosis. Furthermore, IBS subgroup in patient with the IBS optimization criteria shows the lower incidence of the hard endpoint, cardiac death or composite of cardiac death or MI and stent thrombosis. Therefore, use of the intravascular imaging, the result in the reduction of the hard endpoint. This year, the Renovate complex PCI trial was reported and published in the New England Journal of Medicine. In the result of the study, imaging-guided PCI was quite favorable compared to the angio-guided PCI, particularly in the left main and the CTO and the long region. In the Renovate complex PCI group, compared to the angio-guided PCI, the imaging-guided without stand optimization, the clinical event, incidence of the clinical event is numerically lower. However, this value does not achieve a statistical significance. However, in patient with a stand optimization, there was a statistically significant statistical significance. It means do imaging and additionally try to achieve the stand optimization criteria. This finding is particularly in the CTO subgroup analysis. When you use compared to the angio-guided CTO intervention, the stand optimization, the criteria is the statistically significant achievement of the lower the clinical event. What about the left main? This is so famous, 5, 6, 7, 8. is that this is some criteria for the left main PCI, and what about the clinical outcome? When the patient and the achieve this kind of the criteria, the clinical outcome is quite favorable compared to that who does not meet this criteria. As we know, there are several numbers of the optimization criteria. There is a two absolute criteria, minimum stand cross-sectional area, 5.0 or 5.5. And the 5 variable is the relative criteria, minimum stand cross-sectional area more than 100%, 90%, and 80-100% more than a distal reference lumen area, or the more than a 90 or 80 than the average reference lumen area. This is the several criteria. We validate this. The optimization criteria is really working in the clinical practice. So we validate which one is more important. Anyhow, what is the real instance achieve this kind of criteria? As you see, almost be half or 1/3 of a patient achieve. It means that the achievement of the stand optimization is very, very difficult. Only half of the patient, even though we do the intravascular imaging. Among the 7 variables, the only absolute stand lumen cross-sectional area more than a 5.5 or 5 or this more than a 90% of the distal reference lumen area achieve a statistical significance compared to the between the with versus without the stand optimization criteria. Nowadays, when we do the procedure, we routinely do the post-dilation after the PCI. When we do the post-dilation, it is really working. So we did analyze that compared to the angiographic-guided PCI without the post-dilation. The actually cumulative incidence of the angio-guided PCI with post-dilation numerically lower. However, between the two groups, there is no statistical significance. However, IBS-guided post-dilation achieve a statistical significance. So, therefore, we did IBS-guided post-dilation. What is the mechanism? Compared to the angio-guided PCI without the post-dilation makes the use the more bigger size of the stent, more high pressure. It makes the more bigger size of the MLD. This kind of the immediate result was a translate long-term clinical outcome. Therefore, compared to the angio-guided without the post-dilation, the IBS-guided post-dilation significantly reduced the long-term clinical outcome. When we do the angio-guided PCI procedure, usually recommended the stent size, stent to the reference vessel diameter was recommended between 1.0 and 1.1. However, the IBS-guided PCI, usually the stent to the reference vessel diameter was between 1.1 and 1.3. It makes a more bigger size. We can create a more bigger size of the stent. Therefore, ladies and gentlemen, I'd like to conclude that the bigger by using intravascular imaging makes more better. Second was do intravascular imaging for complex PCI. Finally, do your best to achieve optimal imaging criteria. Only 40%, and try to achieve that. Thank you for your attention. Thank you.
Thank you, Professor Hong, for the elegant presentation. So I think we have around 5 minutes for Q&A and discussion for all these topics and live cases. So any questions, comments will be welcome.
I have a question to Dr. Koo. Thank you for your nice presentation. Now we have several modalities to evaluate coronary physiology. So is there any your preference according to the region characteristics or region types?
So you mean in terms of resting hyperemic or the angio versus angio-directed or the invasive physiology?
Yes.
Yes, so So for image-derived physiology versus invasive physiology, I would say that we are accumulating more data supporting that the image-derived physiology works, but it still needs a further data, especially for ostial lesion, bifurcation lesions. So for simple lesion, it's fine, but complicated lesion, we may need more data, and we still need a invasive physiologic assessment. And for FFR and non-hypertonic pressure ratio, there are still ongoing issues about whether IFR guidance will really include increase the risk of all-cause mortality, but it can be either bias or the true finding. But if it is truly important lesion for proximal AD and a left main lesion, I prefer to measure both. And if one is significant, I generally follow that direction. But it's my kind of personal practice.
How about the QFR? Because these days the QFR is a starting stage to adopt that in the everyday clinical practice. What's your opinion about the QFR?
Yes, so angio-derived FFR, it works. So we're going to have a simpler version of QFR as well. But I still have some doubt about the complex lesion subsets such as a bifurcation, left main, and long diffuse lesions. But still for a simple lesion, I think it's still fine, because we have a data supporting that it's better than angio-guided. And we'll soon have a comparison between QFR versus invasive physiological assessment, so then things will be much clearer then.
I have a question that Dr. Koo about the IFR and then FFR correlation. Is generally the IFR and FFR well correlated, but sometimes it is not correlated well. And then the FFR, at that case, I always check up the FFR again and decided according to the FFR value. So why, I don't know, so why is that discrepancy has happened?
I think it's natural because the non-hypertonic pressure ratio reflects the resting condition, resting hemodynamics, and FFR, the hyperemic hemodynamics. So it is natural to have a discordance around 20 to 30%. And having said that, so the question will be, what should I do if there's a discordance? So we have a 2-year outcome data and 5-year outcome data. So at 2-year follow-up, when there is a discordance, the event rate was similar to both negative. But at 5-year follow-up, when there's a discordance, either IFR positive or FFR positive, the outcome was similar to both negative. So what I learned from those clinical outcome data was that the discordance is worse than both negative and maybe better than both positive, but in the long term, it will be the same. So that if there's a discordance, you must be very seriously about fixing the lesion. So that's the lesson I learned from our data, but I have to say that the case number isn't that big, so we may need more data.
Any more comment?
Also, I have a question to Professor Hong. So that so after the Octopus data, so maybe you asked that Dr. Professor Park is there any change after the Octopus data, the presentation? So what's your opinion about the OST and IVUS in the clinical practice? Yeah.
I have a bias.
In the bifurcation, OCT is effective to understand the sideline guideway recursion points. So, but in my practice, OCT is effective by bifurcation. However, most of the cases are equal. So, in my daily practice, 60% is OCT, and that is all.
Finally, Dr. Ho, your comment.
Okay, actually, I want to ask Dr. Hong a question, honestly. Because FFR is in the guidelines, Class 1A, in everywhere in the world, in American guidelines, in European guidelines, in Japanese guidelines, in Chinese guidelines. But when it comes to IFUS, now still Class 2A. Why is that? Because with so many data out there, and I know Professor Hong spent almost 30 years on building the data on IFUS. So what is the hurdle? Why the guidelines still Class 2A, not Class 1A yet?
Probably following the Williams same question, because Gary is disappointed regarding still the 2A indication, especially the complex PCI. But a lot of data has been proved, even the randomized data. So I don't know. We might be. My guess is the Medicare system, because if the European or the U.S. guideline become changing 1A, if you don't use the imaging guides, that was Medicare is a lot of big burden. So this is maybe one of the questions.
Okay, I think I'd like to say thanks to all panelists and the great cases for the 3 live demonstration. I'd like to close this session. Thank you.
Long day.
Yeah.